All right, so Jackie, I noticed that you're on. If you want to take this away, you've got the floor. Just let me know when you want me to.
Yes, Debbie starts the presentation though.
Okay.
So today we're gonna present a case study on a medically complex patient who had a complaint of acute back pain that was unresolved. So before we present the case, we're going to give a little bit of history on him because he is quite complex. My next slide, please. Perfect. So this individual, this is his relevant medical history. He was diagnosed with renal failure, and a fistula was placed back in 2014 for dialysis. He was also diagnosed with diabetes back in 2014 and a concurrent diagnosis of hypertension. He does have a history of hepatitis A and hepatitis C. He has a history of alcohol abuse, hasn't drank recently, but does have a history of it. And then, of course, some medical findings of neuropathy, retinopathy, and then a new diagnosis of heart failure that was made earlier this year. Next slide, please. So a quick sequence of events for this gentleman, as I'm sure we're all becoming more familiar with. Back in May 2017, he was again complaining of this acute back pain. Went to the emergency room, and the ultimate diagnosis ended up being pneumonia and acute diastolic heart failure. So at that time, he was discharged home with oxygen and was to be seen by cardiology to manage this new diagnosis of heart failure. He presented again to a gastroenterology specialist in September because he was complaining of nausea and I think it was just nausea and some pain in his belly. So gastroenterology consulted and did an abdominal CT showing nothing super severe, but they did see that there was some type of fluid in the hepatorenal recess. And they recommended that he start a PPI and some Carafate and continue to follow up with GI and have an EGD done. And then fast forward to October this last month, where he re-presented to the ER for another complaint of acute back pain, at which time they performed an EKG, which was benign, performed a lumbar x-ray in the setting that it might be an exacerbation of arthritis or something of the sort, and found that the x-ray was also negative for a fracture or any type of osteoarthritis. So now we can present the presentation if you have it. Sorry.
All right, hang on just a moment here, and we'll get you into.
So this current presentation is after the patient follows up from his ER visit to the primary care clinic with the labs and the conversation after the ER.
Okay. Can you guys hear me? Can you hear me?
Yes.
Okay, so he went to the clinic that I'm been a student there, and he's 54 years old. He's a little overweight. His BMI is 34.6. He's Hispanic, and he's you guys can see his medications there. Mainly are for blood pressure, and then some of them are for his abdominal pain, the omeprazole and the other ones. I don't know if you guys want it. And then also he had diabetes. He was using the Flex Touch 10 units every other day because after he was placed in dialysis, his A1C got better. I guess that once they start dialysis, their A1C improves. So he was only using his insulin every other day. And his blood pressure, it was a little elevated, but not bad. The main shift complaint for this patient when he came in is severe back pain. And what is interesting about this patient is that he said that he started experiencing this back pain when he was in dialysis. that he was laying down in the bed where they, or the chair or whatever they do the dialysis, and suddenly it just came, and it was acute and it was severe. It was a 10 out of 10 and it did not go away. Then he goes home, and that's when he decides to go to the ER and complains about that back pain. So he says that his pain was worse if he sits down or walks. And then he also had the chronic abdominal pain, but it wasn't as bad as the back pain. And it was only 2 days after he went to the ER, they gave him some, I believe, if I remember correctly, they gave him some Percocets that he did not help, and he was unable to sleep. When I did the assessment, he was moving really slow, and he was he could do range of motion, like turn his back, sit down, and get into the table, but really slowly, and he had a lot of pain. He was complaining of right upper quadrant pain when I palpate his belly, but he said that that was not the reason he was there, that he had that chronic pain and on the stomach, and that he wanted us to take care of his back pain more than anything. And he was wondering why did it came so suddenly after dialysis or during dialysis. Like I said, he could have all the movements we assess for back, but with a lot of pain. His heart sounds were normal. He had good skin. Well, yeah, he had good skin. His cap refill was less than 2 seconds. He had a fistula in his left arm that was really big. His lung sounds were clear. I didn't hear any, because he had pneumonia back in May, but I didn't hear any crackles or anything out of the abnormal. And when I lay him flat in the table to assess his belly, that's when he complained of his pain to go more. Can you go up? These are the labs done. Some of them were in the ER. The 1014 were the ones for the ER, and the other ones were before that. We did an A1C that day at the clinic, and it was 6.1. His cholesterol were elevated. HDL was low, but he was already taking something for that. You guys can see his ELTs and ASTs that were not elevated, even though he had the Hep C positive. And when they did the ultrasound of his belly, he had some ascites, some fluid there. His BUN and creatinine were very elevated, but that's why he was a dialysis patient. It was 38 and 8.5. His glucose that day was 140. His GFR, I've never seen a GFR of 7. So that was pretty low. Amy's laughing back there. I can hear her. Potassium was 4 and platelets 159. So his labs, other than the renal failure, were not significantly abnormal. I'm not sure why the printing or whatever, but the bottom box says talks about the Hep C being positive, and then Hep A being non-reactive. The Hep B non-reactive, but Hep A reactive. And then we have a super high RNA quantitation. But this patient was gonna go to Hep C treatment, and I wanted to include these labs because we just had the lecture for Hep C, so we can start thinking about what we can order. But what else can I tell you? He was HIV non-reactive, and he was also the most genotype type 1 that we see in Hep C. His INR and PT were normal, and that's what his presentation was, his severe back pain. So we can go back, Debbie, and I just want to mention the questions that we had. So you guys hear the patient and putting the whole picture together.
Yeah.
So me and Debbie wanted you guys to start thinking about what your differential diagnoses are or what things you order. So Debbie's gonna take it away.
So when we talked about this patient specifically, we talked a little bit about, as a provider, what are your primary concerns at this visit today? Does anyone have any thoughts on that? He's here for an ER follow-up for acute back pain that doesn't sound like it has resolved.
I see.
Is that interfering with him sitting in his dialysis chair for 4 hours? Is he still able to go to his dialysis?
He hasn't been to dialysis since, because he hadn't been there yet. I mean, he's probably going to go the
So it
next
looked
day.
like he was going to be able to go and sit 3 or 4 hours of the treatment. Wasn't any interference in dialysis.
I think he was going to be okay.
I'm sorry, this is Cynthia. So he developed the back pain during the dialysis session.
Yes, what he told me is that he was getting his normal dialysis. He was just sitting there, and there was like a severe acute back pain to the mid-lower back. And that's when he decided to go to the ER.
So he went to the ER immediately after dialysis?
No, not immediately. He went home, and then a day after he went to the ER because nothing took care of it. Resting, sitting down made it worse, walking made it worse, and he wasn't able to sleep, so he decided to go to the ER. So I see some, Debbie, you want to talk about the chat that the people are sending?
I could go ahead and tell you some of what we've had here so far. For concerns, we have osteomyelitis is 1, 2, a question about clots, 3, an aortic aneurysm, and then there's a couple of questions here specific about whether the back pain was something he was having for his first ER visit. It's the same back pain. And then
No, so the first ER visit was done in May, and they found pneumonia, and he was treated for pneumonia, and then he was released, and he was sent to cardiologist because they felt that he had some heart failure on top of pneumonia, and he was being seen by cardiologists. And then he had also the severe chronic abdominal pain, but he said that this was different.
Okay, so I'm sorry, this is Cynthia again. I just, the reason I was asking about when the back pain started is it could be related to what they're setting as his estimated dry weight. So they kind of calculate what the dry weight would be when they're dialyzing a patient. So they may be actually taking off too much fluid, which could actually cause cramping to the back and to the abdomen. And so he's actually could be dehydrated.
Was he having complaints of cramping elsewhere? Because most dialysis patients get cramping in their legs, stomach, often even before back.
Yeah.
That's back pain.
His back pain was mid to low back pain, and he did mention that they had him in a restricted fluid where he could not take more than 12 to 1500 cc's of whatever fluid during the day. He didn't look dehydrated though when he was there with us in the office. His blood pressure was actually a little elevated, not bad, but he didn't look dehydrated. He had a good pulse. His skin was normal. Unless to me he didn't look dehydrated, but I thought about that too, that they were pulling fluid too fast.
His blood pressure also would drop if they were pulling too much fluid. He would have been hypotensive likely. I worked in dialysis for 20 years and it's not a typical response. So my personal thoughts, having that nephrology experience working in dialysis, it doesn't seem like a typical dialysis, brought on by dialysis, other than the fact that he's confined to a chair, which if he had some sort of musculoskeletal problem, that certainly 4 hours of sitting in a chair may not be effective, or may not be, making his back problem, whatever is fine. But you said he's had X-rays, he's had CT scan, MRI.
I'm sorry?
MRI, he's had an MRI.
Not an MRI. He did have a CT scan, and it only pelvic, and it only showed the fluid in his peritoneal area. I'm trying to read.
But it sounds like you've not had any imaging yet of the spine.
Not the spine, and that's
X-rays.
We had lumbar
X-rays.
X-rays.
Just regular X-rays at the ER. That's all they did. The
Okay.
CTs were done earlier because of
So-
No,
that
no,
would be
no,
the next
no pain with leg lifts or anything that might indicate it's lower back discs or anything of that nature. Numbness.
no
Radiate.
numbness. No numbness. He could feel everything. He could move with a lot of pain, and the main thing was that sitting down was exacerbate his pain, and walking, laying down flat was better, but he wasn't able to sleep.
I would think if it was dialysis related too, that would resolve as he went home and was drinking his fluids and treatment. It doesn't sound like it's resolving between treatments. It's constant.
I think it was just this episode that happened. He's been in dialysis for a couple years already, and this was the first time it happened.
Since it started happening, though, it's constant. It doesn't go away.
No, it didn't go away. So he had his dialysis. He went to the ER, and then 2 days later he went to us, and his pain has never moved from 8 out of 10 to lower than that, even with the Percocets that they prescribe. So the next question, if you want to go ahead and say it, Debbie.
So based off of those differentials, if you want to go to the next slide, actually, we showed some of our differentials, thanks, man, which are pretty similar to what you guys are seeing here in the conversation, just to give you an idea. But given what our main concerns are, of course, the next question would be, what tests would you order? And I know Ian said that he'd want an ultrasound. We talked a little bit about x-rays. We did have lumbar x-rays, but maybe an MRI of the back to see if there's something going on in the spine. Does anyone have any other ideas for tests that you might perform to try to rule out anything else that might be going on?
Maybe like a mesenteric Doppler or some sort of renal Doppler to check his vasculature to make sure he doesn't have, again, you've got renal thrombosis, and I think that's.
He's having some sort of ischemic event. That's gonna hurt.
Certainly, I'm still not completely unsold on the musculoskeletal.
Right. Yeah. Okay.
Any other ideas, guys?
There were a couple other things here that were listed on our chat. One was perhaps pancreatitis, and the other two here looks like compression fracture and spondylosis.
I have a question. Would that compression fracture show in the X-ray that they did at the ER, though? I think it will show, so I think we can rule that out, because they did X-rays of his back and the ER and didn't show anything.
Depending on the type of fracture of the vertebrae, though, it might not show up on X-ray.
Oh yeah, I remember you said that yesterday, right?
Yes. Thank you. I was thinking that. I didn't want to embarrass you.
Don't worry, I don't get it.
Certainly, renal patients are predisposed to bone health issues with their phosphorus, calcium, metabolism issues.
He had no trauma. I don't know if she said that.
Yeah.
If he had any measure of his bone density at all?
Nothing.
So he wasn't lifting anything. He wasn't exercising. He was just sitting down.
So I think Katie asked this, but was there any point tenderness? Was he able to point to one spot, or was it just more generalized?
He would say it was from mid to low back. It wasn't like in a specific point. So we ended up ordering an ultrasound. Or Vigasphere was the first aortic dissection or aneurysm. The rest of the, you want to talk about it, Debbie? Go ahead.
So in real life, an ultrasound was ordered just to evaluate for any severe concerns for aortic dissection. But some of the other things that we had talked about is assuming he wasn't going to his hepatitis C appointment, maybe ordering a fibroscan and seeing how progressed the liver is into the cirrhosis or into the hepatitis C to evaluate for cirrhosis. Because he had another complaint of acute back pain back in May, I was kind of thinking what Carly was thinking. Is it the same type of pain that he had? Should we get a chest x-ray to see if maybe he's coming up with pneumonia again or some type of pulmonary edema that isn't really showing physical signs such as shortness of breath or dyspnea. We talked about maybe getting some new LFTs to reevaluate the liver functions. Those were done back in March. And then maybe an echo to evaluate his cardiac function, since there wasn't any tests that I had seen from cardiology that showed exactly how well his heart was operating.
I see Heidi is saying that if we did a CBC, if we didn't do a CBC, maybe that was a good idea. He didn't have any fever though or tachycardia, but that's a good thought to do a CBC.
I was looking it up on up to date. It seems like back pain occurs in 2 to 5% on hemodialysis patients for unknown etiology, but one reason is infection. So yeah, this is like such a cool case. I'm so impressed with you and the complicated nature of those patients that you're seeing.
I know.
Growing up.
Did they do a CBC at the hospital? I don't remember. They didn't.
I think
don't think so.
I think they did.
I think they did.
I think they did. Give me a second. Yeah, they did a CBC and it was normal back in the hospital, but I'm not sure if it will show right away an elevated white count. Well,
just for the sake of discussion, although again, to preface this, diseases don't read books, what's the most common sense, or what's the most common sensation with people who have a dissecting aorta?
Like a burning, tearing feeling.
And it's oftentimes, having worked on a few people who've had this going on, which can freak you out, anywhere from in between the shoulder blades down. And it's usually in the thoracic region. Usually if you start getting down lower, that's a little different. And you're probably not going to be able to reach around and grab their musculature, push on it, and have their pain increase.
well, I had a patient when I was a flight nurse that had a aorta dissection, and his pain was mid lower back. We didn't know he was dissecting, but he actually ended up dying when we flew him from Santa Fe to Albuquerque, and he bled. But he is I don't know. It's hard to tell when they're doing that.
Right.
But when this patient was telling me, that's all I could think about. And we were talking about intuition last time. And whose lecture we were talking about intuition? But well, we ordered an ultrasound, and I'll tell you the results in a little bit. But the other question that we had was, would you order any narcotics, and which ones for this patient?
Do we know what we're treating yet?
Back pain. Well, we were gonna order some testing, and then we were gonna decide. We were gonna order tests, and then we were gonna order something so he can treat his symptom. So would you guys wait for the results, like Kate says?
I think it would give him motivation to complete the tests if he was in a lot of pain.
Well, I honestly don't remember what we ended up doing. Do you remember, Amy?
I think he still had some Percocet left and it wasn't really helping him, but I don't think we gave him anything different. We didn't do anything. We didn't give him anything stronger. I think he still had some Percocet.
Yeah, I think we told him to keep taking the Percocet, but it wasn't even helping anyway. But
Like an anti-spasmodic, like a back.
I'm trying to remember what we did. Did we give him something like that? Did we give him Flexeril? We did. I think we gave him like Flexeril.
we did give him a Flexeril. I remember because we were talking about that.
Yes, I think we did. Thank you.
Not much help.
Well, I haven't seen him back.
Okay.
So we did order the ultrasound because that was our main concern, but unfortunately he didn't go. So I don't know what happened. And he didn't. I guess he didn't show up to the appointment. He had a follow-up, Amy, and he didn't show up.
Yeah, I don't know about when his follow-up with me was, but his ultrasound was for last week, and of course we gave him ER precautions, but he didn't show and he didn't reschedule it.
Yeah.
So.
Well, the patient said that he didn't, I was reading what Heidi said. The patient didn't know. He's like, help me. I don't know where this pain is coming from. Like, I have no idea. I don't remember asking him, what do you think it is? But he said, well, I don't know. I was just laying there and it came to me and I can't sleep. I can't sit. I can't walk.
Okay.
He'd already tried gabapentin.
Okay.
For his neuropathy.
Yeah, I mean, this was such an acute thing, and those take a while to work.
Absolutely, yeah. Yeah.
But I think the last thing he said, maybe he got better. Well, I guess he probably did, which is why he didn't go.
Right.
Maybe the Flexeril helped, maybe.
Maybe the aorta finished dissecting.
Yeah.
That's true. That could be one reason why he didn't show.
Okay, let's hope that wasn't the case.
I hope it didn't, but I mean,
No, because my MA actually called him. I think she called him and said, did you go? Or I don't know how she found out he didn't go, or she called the place. Maybe she only called the place, so it's a differential there.
Was there some communication between the dialysis unit and staff?
No, they just said go. They just said no.
Oh, so
they had nothing. They just said go to the hospital or no, absolutely not.
So we wanted to present this case because he had so many things going on, and it was related to what we had the lectures this last week, which is narcotic prescription, also Hep C, and then I thought it was interesting, and I was sad that he didn't go to the ultrasound, but maybe he got better, like Ian says. If you guys have any other questions?
be nice to get a follow-up on this one. I mean,
I'll
Yeah.
get back. I see him regularly. I've seen him for years.
yeah. I mean, what if it's a transportation issue?
Well, let me
Never
tell you, he goes to dialysis. He's gone to GI several times because of this chronic abdominal pain. But he's been pretty good. He was extremely non-compliant in the past, which is why he ended up on dialysis. He had uncontrolled diabetes longer than 2014 for many years. I think I just started seeing him in maybe 2014. But, he's actually been pretty compliant with
Yes.
his appointment. So I don't think it was transportation. But I'll find out and I'll let you know.
Thank you. Well, any other questions, guys?
Jacqueline will let you know. She'll be there.
I will. I'll put it in the text. Debbie, you have anything else to say?
I thought you guys did a really good job. It's a very interesting case.
Thank you.
Very well fitting with your class of chronic
With a multimorbidity patient, right?
morbidity. Yes, very good.
Pick any renal end-stage patient and you'll find them with a dozen other diagnoses.
That's right.
Yeah.
Because that's not the only thing that goes bad is the kidneys.
The other thing that I was that is interesting to me is his AST and ALTs, and I hope he does go to the Hep C treatment to see how bad his liver disease is, because I've learned that usually their labs go to normal or even lower than normal when they're in the end stage liver disease.
Right.
But
They're very
usually,
cirrhotic.
the platelets usually.
That's what I was
yeah.
surprised, his platelets are very
Yeah.
good. I thought
Yeah.
for sure
Well,
his
they were-
platelets would be.
They were borderline
Oh.
159.
Yeah, but I thought they'd be in the 80s, 70s. I was very surprised
I have
about
a
that.
lot of cirrhotic patients that have normal AST, ALT, alk-phos, bilirubin, but their platelets are usually lower.
Oh, okay.
Yeah. Right. Yeah.
Yeah.
Some of the fiber scans are excellent. It's very compatible to a biopsy.
And a lot less painful. Biopsies are very painful.
We'll let you know what the Hep C doctor does and what tests he orders.
Too bad Aaron's not on. I'll have to get after him, see if we can get him on again. Okay, any other closing thoughts on this very fascinating case? Hopefully we'll get to hear back on this and what we find out with it. Looks like there's something for all of us to learn on this one. All right, and does that cover our cases for the day? All right, well, a couple of thoughts here. One, there's been some discussion offline about the need to do the